Hi, everybody. Welcome. I guess I should say welcome back to myself too. It's been a short hiatus. Maybe if there's time at the end, I'll pop some kid photos in the chat. But today is about Aaron Meyer and what he's going to present to us about. Um, for those we had the beginning of this discussion, I think it was a couple of years ago, and there's been a lot of talk about SB 43, and we really wanted to get someone who is an expert in this. I know Dr. Bamford knows quite a bit about it as well. Hopefully, there'll be some lively discussion, but I think it was in um November or December where this came up again, and we said let's get someone who actually knows what they're talking about. So Dr. Aaron Meyer is an assistant clinical professor at UCSD. He supervises trainees at a federally qualified health center and works with the city of San Diego as their first behavioral health officer. His advocacy interests also include increasing access to care for those with cognitive disorders and substance use disorders. And for those who don't know Aaron, he used to be sort of seemed like the sole inpatient psychiatrist at Hillcrest and did such an incredible job. And obviously, we were sad to see him move on to maybe greener pastures. But it's nice to see you again. So thanks, Aaron, for being here.
Yeah, thank you very much for that introduction. And I loved my time on CL. It was great. And part of this talk is because of that time. So so I wanted to talk about SB 43, but I also wanted to lay the foundation for how we got to SB 43 and the failure that led to it. So this was from if I can if I can, maybe I'll have to minimize. This was from the May revise just a couple days ago. And it's not liking my embedded link.
Was
Uh,
it not when you had it bigger? Was it not clicking either? Because we could see it. Oh,
yeah,
mm, I'm so bad at this, helping with things like this.
let
Maybe
me,
doing it straight from the browser.
yeah, let me see if I can do it straight from the browser. Uh, Hold on one second. And I'll do it straight from the browser. All right, how's this?
People are dying. Kids are being born. Overdoses. I met a young man, literally, was out there doing Project Homeless Connect, reaching out near the 405 freeway. I found out the next day he was dead in this name of compassion because we had a notice. I could have helped him that night. I felt like a fraud. I felt like I let him down. We got to be more aggressive. I saw a young child, a young kid in San Diego who was with the mayor of San Diego right before his state of the state. This poor kid was addicted to meth. He was a wonderful kid. And he said, I'm really glad you came. He goes, I'm struggling. And there in the tent with his wife was a newborn baby. He said, thank you for coming. There's no compassion in denying what the hell's going on in the streets and sidewalks. They need to step up. Enough of the rhetoric. I'm serious. Enough of the rhetoric. People are dying in this state. It is a disgrace. It is one of the principal reasons people are so angry. They don't trust politicians. They don't like what they see. I'm sorry to get so intense about it. It's a moral issue. They need to do their job. And if they can't do it, let me know. Just say we give up. And then we'll intervene. We'll come up with different strategies and different approaches. But I'm sick and tired of all the barriers and all the BS and all the excuses.
So I wanted to talk about where those excuses came from in this presentation. So when we talk about LPS, and now I can't, Hold on, hold on, hold on. I want to be able to see people. All right, I'm just going to not be able to see you. All right, so when we talk about our inpatient psychiatry, when we talk about LPS, we often refer to LPS, but how did we get there? And so this is from that
Aaron,
report.
your slides aren't up.
Oh,
Sorry, yeah. And maybe that was why. I don't
maybe
know.
that was why. Yeah.
And now you can see two of us.
Oh, thank God.
There we go. Someone
I was,
else is turning
I
on
was,
their camera.
I was
You're good
getting,
now? And
I
then,
was getting
yeah.
so lonely. All right. Okay. So, so that report that I showed on the first slide was from a 1966 report that led to the LPS Act. And the LPS Act, obviously, is what we're living in now. It stands for the Lanterman Petrus Short, which were the two assembly members, one senator, who signed a bill in 19, who the governor signed their bill in 1967, which created much more due process for a system that was sadly lacking it. And so why do I say that? Well, this was the law before the LPS Act. So mentally ill persons could be involuntarily sent to state hospitals who are in need of mental condition, who are of such mental condition that they are in need of supervision, treatment, care, or restraint. And so that is very vague. And you could either meet one or the other criteria. So B was that they were dangerous to themselves or to the person. And so you didn't even have to have dangerousness to be committed. And so this led to significant uh, abuses. And so what did they call mental illness? What we still don't have a definition for it, but in the past it was uh, defined as one of three of these causes. So certain physical disorders, toxic conditions, or injuries can affect the brain, and that can alter behavior. That's much more integrated of an understanding of mental illness than what's been uh, created in our California Code of Regulations. There's personality characteristics, or you can even have mental illness from sudden changes from a rural to urban living can produce attitudes and styles of behavior which differ from the norm. And so uh, these characteristics of mental illness were somewhat vague as well. And so enter the pendulum. And there were people who were very upset that mental hospitals were being told to function as boarding nurseries for unreconstructible Peter Pans, which is for old people, and pink and blue ribboned panel institutions for naughty folks. So this led to the pendulum swinging on closing of state hospitals. And people were upset because of warehousing. One person cried out while being ushered from a commitment court, "Why am I so miserable when you are helping me so much?" Uh, and what you had is warehousing, and what was lacking was really an individualized approach to the individual. The you know one person described it as the whole crux of the matter is individualized treatment. We don't take a bunch of people suffering from pneumonia and paralysis, polio and cancer and throw them all together into a big institution and treat them all alike, or just keep them there as in a storage bin. We give them individual treatment. And so that was sorely lacking for a number of reasons. But what was known is that the average length of commitment hearing in the state was 4.7 minutes. And it wasn't just a 1 year period maximum that you had with the LPS Act currently. It was indefinitely. And if you could basically be put on parole and be able to leave and be with your family, but then you could be brought back involuntarily without any hearing. You're basically committed for life. They talked about beds being pushed so close together that there's scarcely enough room between them to permit a patient to get out of bed. It goes without saying that there is no room on these wards for individual lockers or for bedside tables. This overcrowded state is dehumanizing and antithetical to acceptable patient care. So this was the backdrop of what the LPS Act attempted to deal with. And what hasn't been fixed in LPS is the county variance. And we know because we see it that the most severe individuals don't get help, but the least severe individuals, there is a system for. And this is talking about Short Doyle in the graph. Short Doyle compared to the state hospital. Short Doyle was the county funded, or the county had partial say in how these Short Doyle funds got spent, and a much higher percentage was spent in personality disorders, psychoneurotic or anxiety disorders, alcoholism, whereas in the state hospitals, a much greater percentage of people were cared for had schizophrenia. And that this discrepancy exists today in terms of county infrastructure and county assistance to people with the most severe mental illness. So I thought this was a helpful depiction of part of the reason also why we're in the state that we're in. And so when we're talking about addiction and SB 43, it's helpful to know why alcoholism was separated from mental illness. It wasn't until DSM-3 in 1980 that substance use disorders became their own independent classification. And so mental illness was separate from alcoholism, which was up until this point considered either a sociopathic personality disturbance or a personality disorder. And so this really set the stage for a different view of how we treat substance use disorders. This was how pre-LPS it was determined that, so if it appears to the magistrate on the basis of the affidavit that the person is so far addicted to the intemperate use of habit-forming drugs other than narcotic drugs as to have lost the power of self-control or is subject to dipsomania or inebriety, the magistrate is required to issue a warrant to a peace officer. So there was a system of care for people with alcoholism up into LPS, and they even talked about how alcoholism is a major social problem and represented 27% of all commitments to mental hospitals were related to alcoholism. So then, and they noted that hospital readmission rates for alcoholic patients is very high. Nearly 1/2 return again and again to the state hospital following their first admission. Current psychiatric treatment seems to make little headway in successfully dealing with this problem. So this all set the stage for LPS, where the goal was a mentally ill citizen may be confined and have his liberties abridged only when proven dangerous to the community by due process of law. So this was a significant change from pre-LPS, where it was a treatment-based determination, where if I thought you needed treatment or your family thought you needed treatment, you could be involuntarily hospitalized. And so this created the dangerous standard that we have now. And so the intent of
Aaron,
yeah.
what does it like? I'm looking up LPS. Does it stand for something?
Yeah, LPS is the Lanterman Petrus short.
Thank
Yeah.
you.
So
Okay.
Assembly Member Lanterman. Yeah.
Okay. Thank you so much. Not an acronym for anything that
No,
we would
not
know,
treatment.
just who it was named.
Yeah. So this is from the first iteration of the LPS Act, and subsection A still stands to end the inappropriate, indefinite, and involuntary commitment of mentally disordered persons and persons impaired by chronic alcoholism, and to offer appropriate services on a voluntary basis without delay, legal disabilities, or stigma. And so where did we start going wrong? Well, in terms of alcoholism and substance use disorders, you can see here, this was on the left, the April 28th, 1967 version. So when any person is a danger to others or himself or is gravely disabled, as a result of mental disorder or impairment by chronic alcoholism. And then in July, just a few months later, they struck it. When any person is as a result of mental disorder or impairment by chronic alcoholism, the impairment by chronic alcoholism is struck. And so that really set the stage for a separate treatment of substance use disorders in California, just a matter of months.
Aaron, do you know why they removed physician from the list of people who could, in the previous iteration, who could ask for the person to be committed? Yeah, health
Yes.
officer can.
Yeah. So that's so before pretty much anyone could go directly to a court and petition for a detention. And so this also, that's a good point. This also, so those people were taken out of 5150 and brought into a 5200 petition. 5200, anyone can go to the county and petition for the county to do an investigation on someone who they thought was gravely disabled. But this also was about who could detain. And so in California is a lot different than other states. Other states do allow health officers, physicians to uh, to detain, but it's the transport that becomes an issue. How is a physician or a health officer going to transport someone who's not willing? So this gets at also part of the detainment part of California, and you only having peace officers or police officers do this. We've expanded to mobile crisis response teams, but this also you pointed out something something important that for a very long time we've had a law enforcement only approach to 5150s, which can lead to an implicit kind of assumption that people who are or people who have mental illness are dangerous.
Thank you.
Yeah. So there were attempts to address this gap in the system created by striking alcoholism. There was a new 5150 that was specifically related to treatment of chronic inebriates, and you could be taken to a facility for withdrawal management. But do you know? But the caveat being the county board of supervisors has to approve it. Do you know how many county board of supervisors approved it in the California's 58 counties?
2.
One, Sacramento, and it closed in like 2008. Uh, and so there really wasn't a system for people with substance use disorders, particularly alcoholism. They tried again in the 80s, and for people with what's the word? Treatment of users of controlled substances. But you'll see in 5343, the third line, he or she shall be subject insofar as possible to the provisions of 5150 or 5250. So any of the psych provisions. So that those three words, insofar as possible, really was an out for all counties to also provide, not provide this treatment to people who were gravely disabled due to substance use disorders. So we've had a long-standing history of not dealing with this issue. And so this is just an interlude because there's been about at least 20 years of trying to change the grave disability statute related to, the gaps in LPS. And it wasn't until 2023, and you can see one of our psychiatrists, Jessica Thackerberry, in the white coat, where Governor Newsom signed SB 43. And so this extended the LPS Act to people with severe substance use disorders, also with people who couldn't provide for their personal safety or necessary medical care. with the intent that no one is going to fall through the cracks. And you can see this is in 5008. This is what it looks like as a result of a mental health disorder, a severe substance use disorder, or a co-occurring mental health disorder and a severe substance use disorder is unable to provide for their basic personal needs for food, clothing, shelter, personal safety, or necessary medical care. The severe substance use disorder has to meet the criteria of severe. You have to, in order to be involuntarily detained, you can't survive safely in the community without involuntary detention. Necessary medical care is care that is determined to be necessary to prevent serious deterioration of an existing physical medical condition, which, if left untreated, is likely to result in serious bodily injury, which means extreme physical pain, substantial risk of death, or protracted loss or impairment of function of a bodily member, organ, or of mental faculty, or requiring medical intervention, including, but not limited to, hospitalization, surgery, or physical rehabilitation. So this could be interpreted fairly broadly. And again, each county is going to determine how they're interpreting that in their 5150 policies and procedures. So in order to meet the severe criteria for substance use disorder, you have to have 6 of these 11. But I'm sure all of you know at the Owen Clinic, there are plenty of people with severe substance use disorder who present to your clinic who aren't gravely disabled, just like there's plenty of people who present to your clinics with schizophrenia who aren't gravely disabled. In order to be gravely disabled, you have to have the dangerousness criteria of either danger to self, others, or grave disability. And so what is that defined as? So personal safety can mean running in and out of traffic, being assaulted, abused, exploited, or a victim of crime, living in unhygienic, uninhabitable conditions at home or other home safety issues, inability to care for your hygiene, failure to thrive, and then necessary medical care. It talks about untreated comorbidities such as HIV, diabetes, cancer, liver kidney disease that's life-threatening, extreme physical pain. So if you're, and I can think of one person right now that we're trying to get into to the hospital who, the only group of people who are trying to care for him outside of community paramedics is the Owen Clinic. He's got a CD4 count of 11, and he had cryptococcus found in his blood, and there's concern that he might have fungal meningitis, but he continues to leave the hospital against medical advice. He continues to elope from the emergency department. He's had more than 100 emergency response activations. And so I really am appreciative of all the, the excellent care that the Owen Clinic is, bending over backwards to try to help this poor guy. But this is, situations like that is why the necessary medical care provision for grave disability is so important. And it can only be activated currently if you're in a hospital setting or if you're detained by PERT or mobile crisis response team. So it can create a sense of helplessness in medical and psychiatric providers outside of a hospital setting. So SB 43 was passed, but it still has to intersect with the system. And you can see in H that for Medi-Cal reimbursement for a hospital for psychiatric emergency services, you have to have one of the following diagnoses: a substance-induced disorder, but only with psychosis, mood, or anxiety disorder. So even though SB 43 passed, if you're determined to have solely a substance use disorder, sorry, where are you going to go? The system hasn't been created for it. And what happens? This was a person who was on a permanent conservatorship. So I engaged in some what I thought at the time was productive dissent. And I tried to get that person to the inpatient psychiatric unit. This was their MOCA. It was clearly terrible. This was after a long period of sobriety. This person uh, was on an LPS permanent conservatorship, as I said, and they said that he didn't meet criteria. And they also said that he was able to provide for or utilize food, clothing, and shelter even when he was permanently conserved. But why? And I tried to get him to the psychiatric unit because on the right-hand side, he was declined from the medical acute medical hospitalization, saying we were told you needed care for your mental health problem during this hospital stay. Your alcohol withdrawal problems were well managed, not severe. California state rules show this is covered by your county's Department of Mental Health. So it's not covered by either. And even if you tried to get him into one of those hospitals, you can see in D at a mental health rehabilitation center that you're excluded if you have only a substance abuse or eating disorder. So along the continuum of care, there is no place for you if you have a substance use disorder. Same thing for if you need a skilled nursing facility, or if you need a skilled nursing facility patch or a neurobehavioral health patch. Any part along the continuum of care, you can see the letter B may have a substance abuse diagnosis as a concurrent diagnosis, but it cannot be primary. And so along the continuum of care, people who are gravely disabled by a severe substance use disorder are not cared for. So after SB 43, DHCS came out with interim regulations that said if you had a chemical dependency recovery services as a distinct part unit in your hospital, you could be treated there, or a CSU, or if you had a distinct part chemical dependency recovery hospital in your acute psychiatric hospital, you can be treated there. But how many of these exist in California or in San Diego?
Zero.
Zero. Zero.
Getting good at this.
Yeah, zero. Only the CSUs. But how long can you be at a CSU?
1
Less,
week.
less than 24 hours. So can you cure grave disability in less than 24 hours? No. So 1238 was signed last year, which expanded the range of facilities that can treat people with substance use disorders and provides DHCS with the authority to approve future facility types. And so what are those facility types? So now you can have an LPS designated site in G, chemical dependency recovery hospitals licensed by the State Department of Public Health, which is interesting because chemical dependency recovery hospitals and their regulations require that they are voluntary. So now you have a law that supersedes regulation and is counter to regulation. You also have designated facilities which include mental health rehabilitation centers. But as you saw previously, the mental health rehabilitation centers were unable to take people with solely a substance use disorder. And so, and why do you think that that's chemical dependency recovery hospitals? There's not a lot of them in San Diego that are serving Medi-Cal populations. Is it because the reimbursement is the same or less?
I think I know this one. It's going to be less.
It's less. It's a third less, or it's one
Why-
third. It's one
why
third
is that?
rate. Because I think if I can hypothesize, it's because the staffing ratios aren't the same, and there's different funding streams for substance use disorder. So the acute day at a chemical dependency recovery hospital is a third of an acute psychiatric unit, which also, as I'm reminded frequently, loses money all the time from the health system. So it surely is not a priority. But this says Medi-Cal reimbursement for involuntary services of a severe substance use disorder shall be consistent with Medi-Cal reimbursement for covered Medi-Cal services provided to an individual receiving involuntary treatment for a mental health disorder. It doesn't say that it has to be the same necessarily, but it has to be consistent. And so this is the first time also in 1238 that requires or allows, I shouldn't say requires, it allows a mental health rehabilitation center to admit clients diagnosed only with a severe substance use disorder. They have to have a number of, they have to meet a number of qualifications, but we have about 400 mental health rehabilitation center beds in San Diego. And I would hope that the new behavioral health director for San Diego County is working with mental health rehabilitation centers to update their contracts to allow for treatment of people with only a severe substance use disorder, because the current language is permissive. It's not mandatory. There's also been 2376 last year, where do you remember where I was talking about you had to be in a distinct part of either your hospital or your acute psychiatric unit to have care for on an involuntary basis someone with a severe substance use disorder? Well, this allows for hospitals to have beds that are designated for chemical dependency recovery services and the acute psychiatric and the acute hospital reason. So every hospital, if I was king, I would make them I would make it mandatory that they would have to designate each bed as for this dual purpose, because it provides more money to hospitals if you have this dual designation, because you can bill for all the chemical dependency recovery services, but the hospital has to opt into it. And I don't know how far up on the radar it is on hospitals' priority wish list, but 2376 allowed for treating on an involuntary basis people with severe substance use disorders outside of a distinct part unit. So this created flexibility in the system. So it said that chemical dependency recovery services may be provided in a general acute care hospital or acute psychiatric hospital without a distinct part, or outside the hospital's distinct part in beds that are licensed for a service other than chemical dependency recovery. So that's great. But again, it has to be utilized. So this brings us to 2025 on this whirlwind timeline. So SB 43 is now live in San Diego County as of January 1. And Jewish Family Services has created guidelines for what it looks like for someone who is suffering from a severe substance use disorder or from grave disability due to not meeting necessary medical care or personal safety. So some of those findings could be uncontrollable vomiting, diminished responsiveness or loss of consciousness, potential loss of limbs. And we've seen people who get amputations due to untreated mental illness, uncontrolled bleeding, cold, clammy skin. So signs of clear like medical emergency. Personal safety, so not tending to personal safety, wandering, running in and out of traffic, inability to care for hygiene. And they even included hoarding to an extreme, causing safety concerns or hazardous conditions. And this one is interesting because 5150 designation doesn't allow you to enter into somebody's home. You have to have a court order for that, or a warrant. So how you would effectuate a 5150 related to hoarding would be complicated in an individual who's not coming out of their home, but is clearly gravely disabled due to inability to provide for personal safety. So let's get down to brass tacks. Are there any facilities in San Diego that allow for this? and because this is where the rubber meets the road, and how this actually works out. And so with intense political pressure, there are two facilities now in San Diego that are authorized to involuntarily admit someone for severe substance use disorder, and those are Alvarado Parkway Institute and Paradise Valley. And so you can see there's on the left hand middle SB 43 admit authorization, and there's also a continued authorization where an inpatient behavioral health unit called and there was no chemical dependency recovery hospital bed available. So even inpatient psychiatric units can treat involuntary substance use disorder even after the initial 72 hours if there's no chemical dependency recovery hospital bed. So if psychiatry says no, they can't do it, they're wrong. I told you so. So there are also authorization requests that have been built out for how you can get somebody from the emergency department to a chemical dependency recovery hospital in San Diego. So there are options, and this is just the beginning. This kind of public policy change is going to take a while to build up and sink in, but it was very important. And so even it was so important that just last month, San Diego County and their Board of Supervisors put out an RFP for a contract for up to 22 beds for an initial term of 1 year and additional 6 months if needed for chemical dependency recovery hospital beds. So not only do we have hospitals now that are able to treat involuntary substance use disorder, but we're now the County Board of Supervisors has put out an RFP for 22 chemical dependency recovery hospital beds. And so this is something where a couple years ago we had 0. Now we may have 22. We also, just this week, Governor Newsom announced the Proposition 1 funding, and we have, as you can see, 4 out of the 7. Sorry, I can't count. 4 out of the 7 facilities that were awarded were adult residential substance use disorder treatment facilities, and I highly doubt this would have been the case if SB 43 hadn't passed. So again, Proposition 1 was a $6 billion bond that voters barely approved a couple years ago. And so 4 out of the 7, and this is true throughout the state. So this was just in San Diego County, but 4 out of the 7 in San Diego County, and then similar across all counties, has been a build out of these substance use disorder treatment facilities. So I think this is really important for people who are struggling with no access to care. So with that, I'll take any questions, but I wanted to provide a brief overview of the rationale behind SB 43, SB 43 itself, and then post SB 43 and the actual infrastructure planning and delivery. So thank you very much.
Aaron, that was really helpful and a really good update. Obviously, quite a storied history, if that's the way to say it. I will open it up. I know there were a lot of people who wanted you to talk about this. I'm hoping they are on. I see some people, they may be involved in other things. There we go. We can start with Anik, but I know there's some people from particularly our federally qualified health centers who had asked a lot of questions. So I'm hoping they will ask as well. But Anik, why don't you kick it off?
Aaron, that was really useful. I was wondering, given there's been so much kind of talk against this SB43, whether you think there's any risk of us coming back to the LPS, situation, or are the new bills protective of that?
Yeah, I don't think there's any appetite in the legislature to go back on this legislation. It would be much harder to go back, and the legislature is different from I bet the bureaucracy, all the county bureaucracies would want to go back on it, but the elected the electeds would have significant pressure to not go back on this. So I don't see this uh, failing because of uh, the legislature. I see this. I see right now the importance of building on infrastructure and counties delivering on workforce and services for this population as uh, the main point that I hear all the time from different California agencies is you
Thank
have
you.
no beds. Well, now you have Prop 1 and all these beds have been announced. And so start taking care of people.
Thank you.
Nettie.
Hi, can you hear me?
Yep.
Thank you so much for coming. I was one of the people who asked Jill to bring you back. That's why she called me out as an FQHC person. I'm at San Ysidro Health. And I really appreciate this conversation, especially around the sort of compassion issues. I see a lot of suffering of patients with grave disabilities, particularly from methamphetamine use disorder combined with underlying, pre-existing mental illness. And it's extremely frustrating to see these patients just cycle through the system and get worse and worse and come in to see us. And these are people we know and care about and who are, experiencing this decline based on the system. So I really appreciate this conversation. I'm curious what you have engaged with folks who feel like this is an infringement of people's rights, or I've heard a lot of reasonable concerns from folks around this law. I see it from the side of wanting to reduce the harm that I'm seeing for patients who, like your example, really qualify and have no place to go. But I have heard a lot of folks say, well, I'm worried about infringement of rights and I'm worried that this bill will be overused. And so could you share with us, or maybe other folks on the call who have those concerns could engage with you a little bit on that side of things?
Yeah. No, I think that's really important. And there certainly is, as we've seen, a disproportionate use of involuntary treatment that's been uh, administered to BIPOC populations. And I think that's one of the reasons why the legislator is looking at a report from counties that look at race, ethnicity, housing status in their reports on involuntary treatment. And the state wants to look at counties where this might be delivered even more disproportionately than has already been uh, reported. And so I think protection of civil liberties is very important. There was nothing in SB 43 that changed anything related to the due process that someone gets if they're involuntarily detained. There's still access to patient advocate. There's still access to a public defender. So nothing about SB 43 changed due process. And what I worry about is something what you mentioned about treatment and what happened pre-LPS, where people were determined that they needed treatment, but they actually didn't get any treatment. It was largely custodial based warehousing. And so if you involuntarily detain someone in a hospital for a severe substance use disorder, but then you don't offer them and recommend evidence-based substance use disorder treatment, how are we any different than what we were doing before? So I think it's a significant responsibility to involuntarily detain someone, and if we're not providing evidence-based treatment, then then I think there's no uh, then I think that's not aligned with the intent of LPS, because the intent of LPS is also for prompt evaluation and treatment. So it can't just be detainment. We actually have to try to reduce or eliminate the behavioral manifestations of grave disability. And so that's one of the reasons why in the current legislative cycle, Senate Bill 367 is trying to update the individualized treatment plans for people who are gravely disabled to include criteria for stabilization, evidence-based treatment, and a step down to the less restrictive alternatives. Because we can't just have an individualized treatment plan that says take a shower twice a week. That's not good enough. And so if we're detaining and taking away someone's determination to where they're living, we need to be just as focused on how we're delivering the care so that we can promote independence and transition them off this very restrictive intervention that's designed to be life-saving.
There's a question in the chat from Chris Matthews. How is SB 43 involuntary treatment provision integrated with the less restrictive Care Act pathway?
Yeah, so I
Maybe
didn't
you
get
can
into
explain that to those
yeah.
who don't know what that is.
So I'll keep you on for another hour for a lecture on the CARE Act, and I can do that. But the CARE
Booked for next year.
yeah.
You, Marvin, you can note it. I'm sorry.
Yeah. So the CARE Act is, there's been a lot of talk about what the CARE Act is, and there's or what the CARE Act isn't. And if you hear one side from disability rights, for instance, you would think that this is a very coercive, involuntary program. If you talk to the city of San Diego, they might say this helps the least severe of the mentally ill, and it's probably somewhere in the middle. So the CARE Act is for people with schizophrenia or other psychotic disorders who are at substantial risk of deterioration or at risk of grave disability. And so far in the state of California, uh, it, I think it went live October 1st, 2023. In their 9-month implementation report, there were 557 petitions filed, and about 39% of those petitions were dismissed. In San Diego, we're seeing 1 in 5 CARE Act petitions dismissed because of someone's inability or unwillingness to engage. And so really the intersection with the CARE Act is when there's been a conservatorship referral request, and the investigator determines that the person is willing to engage in a less restrictive alternative, such as the CARE Act, and their conservatorship recommendation is declined, and the person is enrolled in the CARE Act program. Or you see people who are stepping out of or having their permanent conservatorship terminated, and they're enrolling in the CARE Act program as a means to transition them to a less restrictive alternative. So I think in that scenario, it can be certainly very helpful for those individuals who still need a bunch of support, but don't necessarily need to be in a locked treatment setting. So that's probably the main intersection with the CARE Act program. And the CARE Act program, you can either have a court supervised care agreement or a court ordered care plan. And in San Diego, all of our interventions with the CARE Act program have been on the court supervised care agreement side. And we haven't had any court ordered care plans, I think, because of the philosophical decision on the county part to implement only the care agreement side of the CARE Act.
And Aaron is so Steve Hendricks. I used to work in the emergency room here in Hillcrest, and then so my exposure with this population is always when they're at their worst. Is the hope of this to help bypass the ER or to be more of a landing place from the ER?
Yeah, so that's the concern, right? We have I think the goal should be diverting people away from the ER. And so I think that's part of the reason why Prop 1 is so important for linkages to substance use disorder treatment facilities. But part of the problem in the system, as I see it, is that so many of the, you know, the step down uh, access to the step down continuum is through a hospital setting. And so that's another reason why I think 367 is so important, because it allows for a treating physician or psychiatrist to petition for conservatorship outside of a hospital setting. And because that's currently only afforded to agencies that are designated by the county, but we're seeing ACT teams refer people to the ED, or people, people who are referred to the emergency department who are chronically gravely disabled, but don't necessarily meet the acuity criteria and continue to cycle to the emergency department, and they keep getting discharged. And that's why with the city of San Diego, with their RAP team, like the high utilizer team, we see this all the time. And it's and we're trying to end the constant cycle to the emergency department by empowering outpatient clinicians to be able to have some access to intervene, similar to the CARE Act, where behavioral health or first responders can also file a petition. The CARE Act allowed one of the first access points for non-hospital based providers. And I think the more we can utilize outpatient pathways uh, and keep people in the community outside of hospital settings, I think the more we're in line with the least restrictive pathways for helping people who really need that support.
And just one follow-up question real quick. So then would there still be the option though for disposition from the ER to these facilities?
Yeah, yeah. You're talking about like a chemical dependency recovery hospital, or?
Yeah, I mean,
Yeah.
that's always like, as you just highlighted, right? That's the issue, that there's no place to go. So people come in looking for rehab and there's no options.
Yeah, and so that's a huge problem. And that's one of the reasons why I'm hopeful, because McAllister got one of those Prop 1 grants, $34 million to build like a substance use disorder campus in El Cerrito. And that'll have a withdrawal management, because so often it's difficult to get people into residential facilities because there's no detox, and residential often wants people to be more stable than from the ER. And so we have a significant shortage of detox beds in San Diego County. I'm not saying anything you guys don't know, but hopefully with this infrastructure, there's going to be more of a pathway for people to go to detox and then to residential. But even without the detox, they can be referred to the chemical dependency recovery hospitals. It's just a matter of going through the authorization steps and encouraging psychiatry to look into this.
Aaron, I don't know if you can see the question from Nettie. How can a provider use new SB 43 options to get a patient connected to care? Nettie is someone
I can just, yeah.
disabled. Yeah. Oh, sorry.
Sorry, I
Go
wrote it
ahead.
thinking we might run out of time, but yeah, I mean, it's sort of what you were just saying about trying to empower outpatient, connections. A number of us, see patients who come into clinic fairly regularly with a lot of complications, but don't necessarily voluntarily think that they need to engage in care. And so we've got these people that are like, that's a patient of mine who has severe mental illness and then meth use disorder. So in and out of Paradise Valley or in and out of here. and discharged back to the street or to the shelter, and then loses a shelter bed because of his mental health disorder. And this is just a cycle. And meanwhile, he comes in to see us, and we're, putting Band-Aids on, and his T cells are down to 50. And so, it's tricky because it's not someone you would necessarily call PERT on at the moment, but how might this law sort of help these folks in the future, these folks that we're connected with and we know need more services, and are sort of bouncing in and out of an ER, but not really willing
Yeah.
to engage.
Yeah, so those are challenging situations, and that's one of the reasons why the city has gone forward with several. I mean, we filed about 20 probate filings, probate conservatorship filings in the last 4 years, because probate, you don't have to have the behavioral health agency file. You can do that. Anyone can file in probate court. Well, any lawyer can. So that's been one resource that the city has had to utilize. But another one is county case conferences with behavioral health services, and having them track and document that these conversations are being had. And then also bringing people up like this at the PERT roundtable, because you're right, like sometimes the point of time assessment can be quite limited compared to a longitudinal understanding of where the individual is coming from. And so a forum like the PERT roundtable, where you're talking to clinicians about the situation and why you're concerned, can be another way that it can flag on their radar to not just look at a point in time assessment and evaluate someone more superficially than and kind of miss the grave disability part. So I see two other questions in the chat. Did the legislator fund evaluations of the impacts of SB 43 provisions for involuntary treatment? Who is monitoring benefits and harms on a statewide basis? Both good questions. The DHCS should hopefully be publishing their report soon on involuntary treatment. There's an annual report that needs to be filed. But then as far as the funding piece, I've been harping on the funding piece for a while as well, because Welfare Institutions Code 5014 allows for 1991 realignment funds, 2011 realignment funds, and behavioral health services funds to go towards LPS services. But counties have been very hesitant to show where that money is being spent. And so that's $7 billion annually. And what is that going towards? I think that's why the counties now have to, starting in, I think, July 1, 2026, submit a transparency report on not only the allocation, but also the utilization of all federal and state funds, and what they're doing with it. Because we shouldn't be funding necessarily, more desks, more chairs. We should be funding services, particularly to people who need help the most. And so where are counties spending that $7 billion? I think that's what I would like to know. But there is funding, and even with that funding, we need more. So if a patient won't go to a psychiatry outpatient, are we starting conservatorship petitions, or how do we get help navigating this? So that law hasn't passed. So it's in the Senate Appropriations suspense file. And this suspense file is one of the most undemocratic things about California, where things happen in closed doors. And on May 23rd, we'll hear whether or not things come off the suspense file and are able to get to the Senate floor. So the suspense file is for anything that has a fiscal impact. And so there's not an opportunity yet to do these conservatorship petitions or recommendations as an outpatient. But if Senate Bill 367 passes, then that ability would be, if the law is, or if this bill is signed as is currently, it would allow for outpatient physicians and psychiatrists who treat the person for that grave disability to submit conservatorship recommendations to the public conservator's office.
Thank you so much, Erin. I hope this last message, sorry, I don't think we have time to go through it. But obviously there's so many questions around this, and obviously since it's evolving, like I said, it would be lovely to have you back again at some point to see where we are like in a year from this, and how everything's going. But thank you for, it feels like you're a lawyer. I mean,
I've had to be.
yeah, I feel like that's what's happening in the last bunch of months is that we all have to be lawyers, and a lot of us don't know how to make that adjustment, but it sounds like, or it seems like you have. So thank you for doing everything that you do and being able to translate this for us. Yeah, we appreciate you being here on this Friday morning.
Well, I really appreciate the invitation and to be amongst people who really get it and who are taking care of some of the most vulnerable people in San Diego. So I'm really appreciative and I'm honored to be here. So thank you.
Thanks, Aaron. And thanks, everyone. Don't forget to submit your CME stuff, and we'll see you next week, I believe. Okay, bye.
Take care.